Dear friends, today we will discuss a case of anorectal malformations. First, we will discuss about its antenatal and postnatal assessment, evaluation, and management protocols. We can discuss its definition, embryology, types, associated anomalies, antenatal diagnosis, postnatal evaluation, management, and a complication related with it, pouch colon. Anorectal malformations are complex group of congenital anomalies resulting from abnormal development of hindgut, allantois, and Mullerian duct. They can be isolated in 40% of cases and syndromic in less 60% of cases. Incidence is 1 is 3000 live birth. Sex ratio is almost equal in male and female. Its embryology is normally gastrointestinal tract begin its development early in fourth week as longitudinal and lateral folding of embryo result in incorporation of dorsal part of yolk sac. This primitive gut is closed at the cranial end by oropharyngeal membrane and at the caudal end by the cloacal membrane. Anorectal and urogenital tract are derived from cloaca, the caudal part of hindgut. By the 6th week of development, the cloaca is divided by the urorectal septum into a separate ventral urogenital sinus and a dorsal hindgut. Anal membrane ruptures at the end of 10th week. It is incomplete development of this urorectal septum that leads to anorectal malformation. Types of anorectal fistulas can be in male, they can be perineal fistula where rectum is opening into the perineum, or rectovesical fistula where rectum opens at the bladder base or neck, or it can be rectobladder neck fistula or rectoprostatic fistula where rectum is opening into prostate, or rectobulbar urethral fistula. In females, it can be perineal fistula where rectum is opening into perineum, or it can be rectovaginal fistula where rectum is opening into female genital tract vagina in spite of opening into the normal place at the anus. It can be rectovestibular fistula where rectum is opening at the vestibular opening which is just in front of anus but not at the anus. A type of anorectal formation called imperforate anus can occur in both boys and girls, which is imperforate anus without fistula. His anus is covered only by a membrane and there is no fistula. Classification is wingspread classification divides ARM into low, intermediate and high type depending on location of rectal pouch in relation to puborectal sling. There is Crichton-Back classification which is developed more recently and is mainly based on location, presence and type of fistula. Etiology remains unclear, but it is assumed to be multifactorial. Both genetic and environmental factors have been identified. Maternal overweight, obesity, diabetes, and paternal smoking also seems to be a risk factor for development of anorectal malformations. There can be many associated anomalies along with anorectal malformations like urinary, vesico-urinary reflex, hydronephrosis, renal agenesis, renal dysplasia, or they may be genital abnormalities like vaginal septum, uterine didelphys, cryptorchidism, vaginal duplication. They can be vertebral anomalies like lumbosacral anomalies, tether cord lipomas, syringohydromyelia, or they can be cardiovascular anomalies also like VST, tetralogy of Fallot, transposition of great vessels, hypoplastic left heart syndrome. There can be many syndrome can also be associated with anorectal malformations like trisomy 13, trisomy 21, trisomy 13, trisomy 18, and cat eye syndrome, which include ARM, coloboma of iris, coloboma of choroid, optic nerve, microphthalmia, and variable external ear deformities. They can also be vector association in which at least three of the vertebral, anorectal, cardiac, tracheoesophageal, renal, lymph anomalies should be there. They can be associated caudal regression syndrome which replaces with caudal dysgenesis sequence. It affects the lower back, limbs, genitourinary tract and the gastrointestinal tract. They can be Curarino syndrome which include sacral agenesis, and anorectal malformation. They can also be FG syndrome, which include mental retardation, large head, imperforate anus, congenital hypotonia, and partial agenesis of corpus callosum. They can be cyanomelia, in which legs are fused together, or Townes-Brocks syndrome, in which renal, ear, anal, and radial syndrome is there. They can also be Pallister-Hall syndrome, which include hypothalamic hematoma, panhypopituitarism, polydactyly, imperforate anus, and respiratory tract anomalies. Now, how to antenatally diagnose this condition? It depends on identifying dilated rectum and sigmoid colon, intraluminal calcification, which can be meconium calcification in cases of urinary fistulas. There is also absence of anal dimple, or we can say it is target sign, which is a key indicator of anorectal malformations. Anal dimple normally depicted as hyperechoic anal mucosa surrounded by hypoechoic anal sphincter, also known as target sign. One study demonstrated that between 23 to 34-week gestation, PAMC could be identified in 90 to 100% of low-risk pregnancies. Target sign is normally it looks like this. Center is hyperechoic mucosa surrounded by hypoechoic musculature. It can be anteriorly placed instead of posterior at the place of anus, like this vestibular anus, or it can be absent where line sign is present instead of normal target sign. In cases with abnormalities that are known to be associated with ARM, such as sacral agenesis, hemivertebra, caudal aggression syndrome, if seen, then repeat scan for visualization of PAMC is indicated. In first trimester pregnancy, ARM can be suspected in presence of intra-abdominal cyst. In management, we can be in advanced targeted anomaly scan should be performed. Counseling by a pediatric surgeon should be offered. Genetic consultation can be considered in presence of associated anomalies. Delivery should be at tertiary center with equipped NICU and pediatric surgeries facilities available. Postnatal screening of associated anomalies is recommended. Exact surgical approach depends on type of ARM but usually involves an anoplasty and a temporary colostomy. In case of isolated ARM, there is good prognosis, but depending on type and number of associated anomalies, survival rate decreases. Follow-up cases can show complication associated with ARM like chronic constipation. They can be fecal incontinence in 25% of cases, or they can be urinary incontinence in cloaca type cases, around 40%. Chronic complications like this require evaluation, management, and long-term follow-up. Now let's discuss about case. A 20-year-old lady, primigravida, with normal conception, no IVF, non-consanguinity, with no workup done previously and no ultrasound done previously, reported at center. She was having around 30-week pregnant fetus with normal biometry, normal CNS and spine, normal kidneys and urinary bladder, normal cardiovascular system, but with dilated bowel and absent target sign. Suspecting of anal atresia, she was advised for MRI and follow-up. Her USG findings were normal bilateral kidneys and a line sign, a small line depicted, which showing absence of target sign and anal atresia. There was also dilated bowel in the ultrasound findings. Here in this view, also there is dilated bowel is showing. Here also a dilated bowel is significant dilated bowel is visible. Here also a significant dilated bowel posterior to urinary bladder is visible. Line sign is visible just posterior to genitalia, showing target sign absent. On follow-up, patient reported only 1 month after delivery, no MRI done. It was a normally delivered female child with about 2.5 kg weight. On examination, findings were large distended abdomen, stool coming out of vagina, small opening in vestibular area without any content coming out of it, and no anus was visible. Postnatal images were like this: huge distended abdomen with liquid stool coming out of vagina, and there was false opening near vestibule without any content coming out of it. With distended abdomen, liquid stool coming out of vagina, a diagnosis of rectovaginal fistula with atretic anus was made, and patient referred to pediatric surgeon for needful evaluation and treatment at tertiary center. After pre-op evaluation, baby was taken for surgical treatment. While doing surgery, pediatric surgeon diagnosed a large dilated pouch colon of type 1 and anal atresia with rectovaginal fistula. Stage surgery was decided with excision of pouch colon and ileostomy along with anoplasty was done in first stage, to be followed later on after 4 to 6 months by abdominoperineal pull-through of ileum. Now what is pouch colon? Pouch colon is rare congenital severe type of ARM where colon is replaced by large pouch-like dilatation with total length of colon shortened than normal expected length of 5 to 15 cm. Pouch colon connects to urogenital tract via fistula. There are no tinea coli, ostration or epiploic appendages, and development of mesentery of pouch is also inadequate. Pouch colon is usually vascularized by superior mesenteric artery in type 1 and 2 and inferior mesenteric artery in type 3 and 4. There is no transitional zone between pouch colon and normal bowel. Bowel pattern changes suddenly and abruptly. Exact incidence of CPC with anorectal malformation is unknown, but it is rare outside of India. Pouch colon is most prevalent in India with incidence ranging from 5 to 15% of all ARMs. 92.2% of total reported cases of pouch colon are from India. It is significantly more common in males than in females. Diagnosis of pouch colon occurs after birth, and management requires complex surgery with optimal care, significantly reducing high mortality rate associated with this condition. Its classification by Rao says type 1 is ileum directly opening into the pouch of colon with no normal colon available. Type 2 is cecum is present and rest of colon is in pouch configuration. Type 3, considerable length of normal colon is present proximal to the pouch colon. Type 4 is only sigmoid colon and rectum are in shape of pouch colon. Rest of colon is normal. This is type 1. Only pouch is seen representing whole of the colon. Ileum is seen directly opening in this pouch. And type 2 is only cecum is seen proximal to colon. Type 3, significant length of colon is there and is ready for colostomy. And type 4, all of the colon is normally normal, only distal part like sigmoid and rectum are in form of pouch. Here also it is showing type 1 is whole of the colon is representing into pouch. Type 2 is cecum is seen and rest of colon in pouch configuration. Type 3 is considerable length of normal colon is present proximal to the pouch colon. Type 4 is only sigmoid colon and rectum are in shape of pouch. Rest of colon is normal. It can be complete in type 1 and type 2 in which there is either none or little normal colon left that is insufficient for performing the pull through. In type 3 and 4 it is called incomplete as length of normal colon is adequate enough to perform the pull through without the need for doing a coloplasty. In males, communication of pouch is present with the bladder and fistula opens on the posterior wall of bladder. In females, colocloacal is most common, followed by colovaginal and colovestibular fistula. Pelvis and perineal muscles are poorly developed in pouch colon. In order to evaluate final urinary and fecal function outcome, long-term follow-up is mandatory. Initial follow-up examination is performed after 1 to 2 weeks and anal dilatation program started. Then 3 monthly follow-up for first year and 6 monthly follow-up for next 3 years is recommended. Thereafter, child can be followed up once in 2 years till adulthood. Take-home messages are: always be suspicious of anorectal malformation if dilated bowel along with absent target signs seen in third trimester or late second trimester. Always follow antenatally as well as postnatally, as parents may miss absenteeism. They may not be aware of abnormal fistulous opening, and for them soiling of diaper by feces is sufficient to believe that gut is okay. Postnatal examination to check perineum is must in these cases to see presence of abnormal passage or stool. These are my references from where I have taken content. Thank you very much for your patient listening.